All right, thank you very much. I'm Jodi. I'm a nurse practitioner at St. Luke's Hospital at Aurora Healthcare in Milwaukee. I work very closely with Dr. Tohan in the cardio-oncology program here at our hospital. And an interesting case came upon us a couple months ago, a patient who had an orthotopic heart transplant about 2 years ago and then came to us after having a diagnosis of breast cancer. Was referred to our cardio-oncology clinic just for recommendations as how to proceed. So her history, she's a 42-year-old female. She had a history of severe non-ischemic dilated cardiomyopathy, along with cardiac arrhythmias, ventricular tachycardia, ultimately was worked up for advanced heart failure treatments, placed on the transplant list, and underwent a heart transplant in February of 2015. Post-transplant, she really had an uncomplicated course for the most part, general immunosuppression with tacrolimus, mycophenolate, and then prednisone, which was weaned. Normal prophylaxis with background nystatin, and she had been on some terbutaline for chronotropic incompetence. After those things were weaned, she did develop some recurrent infections, including CMV, bronchitis, and sinusitis. So she has been on a course of Valsite 3 days per week to help keep that at bay. She's been very compliant with her post-transplant clinic visits, as well as her routine screenings. In January, she had a routine screening mammogram, which was abnormal, revealing numerous calcifications to the left breast. She underwent a biopsy. You can see she had ductal carcinoma in situ with high-grade comedonecrosis and microcalcifications, which is ER positive, and so she was referred to us for just clearance for surgery, as well as potential for other chemotherapy agents. I know what we should do.
Let me ask you, can I ask a question?
Sure.
If she was non-ischemic cardiomyopathy, what was the source of the late gadolinium enhancement that was seen on the cardiac MRI on the old heart before transplant?
So she underwent a workup for infiltrative cardiomyopathy, and the workup was negative. So not really sure what that late gadolinium enhancement meant. Workup was negative.
So the pattern of gadolinium enhancement was probably mid-wall, I don't recall. So not a pattern that was consistent with transmyocardial transmyocardial or myocardial infarction. So mid-wall enhancement is not uncommon with diseases like prior infectious etiologies.
Myocarditis, right?
Correct.
Thank you.
All right, so her other medical history, really the primary was cardiac. She's got some anxiety, depression, had been in a motor vehicle accident, had a C-section, an ablation. Social history, never used tobacco, no alcohol, no drugs, exercises occasionally, 2 cups of caffeine per day. Family history, mom had leukemia and a stroke. There was some coronary disease, valvular heart disease as well in her family history. So medications at presentation to our clinic, she was on mycophenolate, sertraline, tacrolimus, pravastatin, lisinopril, valganciclovir, Clinda just prior to dental procedures, vitamin D, aspirin, and a multivitamin. Post-transplant care at our center, we do preventative screenings per ISHLT guidelines, and again, she was very compliant with all of these. So this is just a picture of the diagnostic mammogram that was completed after her screening mammogram, which showed coarse microcalcifications in the left breast. And then she underwent a biopsy after that. So looking at cancer rates for the general U.S. population, in female, breast cancer is the most predominant, in men, prostate and lung. This is just a 2017 American Cancer Society numbers for that. And then this is just, again, from the American Cancer Society 2017 numbers, just showing that breast cancer in women birthed, or people birthed to 49 is the highest incidence of cancer in that population. And then it goes down to depict the rest of the ages and where those percentages are. And then looking at ISHLT registry data, most common cancer types in adults post-transplant include skin cancer, lymphomas, solid malignancies. And the solid malignancies post-transplant also correlate with the general population, being prostate, lung, and breast cancer most prevalent.
Just parenthetically, just so that everybody knows, ISHLT is a very large registry of the International Society of Heart-Lung Transplantation, and now has over 100,000 patients over the last 30-plus years that have been included in the registry across the globe. And it tracks many of the common complications. It has sort of a very cursory look at cancers as a diagnosis, and then follows those patients out. So does not have specifics. It does not have specifics such as whether the immunosuppression was modified or any other types of information that may be relevant or important to the care of these patients with malignancy. So it sort of cries out for a real registry for these individuals.
So then I did research some articles looking for incidence of cancer following cardiac transplantation, and really there was not much data out there. So then I looked at kidney transplant because these patients, there are more of them, and there was more research related to this. Most of the research was a little bit old, 2004, 2007. These were just some good numbers that I saw fairly consistent throughout what I looked at. So incidence of cancer following kidney transplant, twofold higher in colon, lung, prostate, stomach, esophagus, pancreas, ovarian, breast. I'll just kind of go through these. But there was a significant increase post-kidney transplant in all of these types of cancers. Predominantly your lymphomas and skin cancers had a 20-fold increase, kidney cancer 15-fold, melanoma, leukemia, hepatobiliary tumors 5-fold, and then 3-fold of the testicular and bladder cancers. And then this was just another more information, just really emulating the same. So our cardio-oncology consult, typically we take a full medical history, do a full physical exam, really screening for heart failure symptoms in addition to the rest of the physical exam. Typical cardiac diagnostics that we obtain would be a full echocardiogram, a 12-lead EKG, baseline troponin, fasting lipid panel, and other routine labs to evaluate kidney and liver function. This patient's physical assessment was fairly benign. These are her vital signs of a normal weight. Blood pressure was slightly elevated. She had had those chronic sinus infections. Otherwise fairly benign. Cardiac diagnostics that were done for this patient with her annual screening post-transplant were normal. She had a normal DSE, normal left and right heart cath. So we did obtain a new echocardiogram. At time of her presentation to our clinic, and she had normal functioning, normal echo, normal allograft function, normal GLS, normal valvular function. So that brings us to what do we think about this patient and where should we go from there? So really considering implications of treatment given her history of heart transplant. Does that, would we utilize an anthracycline-based chemotherapy in this patient if it was indicated? Any thoughts on that? What about trastuzumab, newer agents, or radiation therapy? I think at this point, this patient has normal allograft function. She is a healthy female on immunosuppression. Looking for data as to what to do for her, there isn't a lot of evidence. And looking at the ISHLT guidelines, they do recommend standard therapy for cancer treatment if the cancer does not involve the lymphoid system, including chemotherapy, radiation therapy, and surgical interventions. Cardiotoxic chemotherapies, such as anthracyclines, trastuzumab, certainly could be utilized with strict adherence to cardiac monitoring during treatment. So that was our plan for this patient as she went for her mastectomy first, and looking at further biopsy results would be that we would proceed with typical chemotherapy with frequent visits and monitoring of her allograft function with echocardiogram utilizing strain imaging. Any comments at all? Or?
No, I mean, again, we brought this case forward because we think that there is a paucity of data, and we treat these patients exactly like we would treat patients who did not have solid organ transplantation, recognizing that immune surveillance is altered in patients post-solid organ transplantation, and the incidences of cancer and other opportunistic infections all reflect this impaired surveillance capacity of the immune system. And so we just thought that this might be an interesting topic of conversation and what to do with these folks, whether there's anything different or modifiable that we can do to improve the outcomes.
Ms. Crone, I think this is a great case. We had a patient here at WashU who did have a heart transplant, and I didn't take care of the patient, so I don't know the details, but I know that the patient's heart just totally failed. So I think this is really fraught situation here, and it's a great case to present.
So can I ask if that individual received anthracycline-based chemotherapy, or did they receive trastuzumab?
Yeah, I knew you'd ask that. I don't know. I wasn't taking care of the patient. It was sort of anecdotal talking to one of my partners. So I'm going to find out before the day is up, I'll tell you that.
Yeah. I mean, there's no registry for this kind of stuff. I mean, we've really scoured a bit. There's some reports from the Penn group many years ago on malignancies, and but really it was somebody was diagnosed with a malignancy. What is the natural history and outcomes? It wasn't like, kind of what we're trying to create, which would be what happens with the therapy, what happens with the immunosuppression, and then what happens with the patient. Because all the guidelines basically just say treat like a normal person, and we know that these people are not normal.
There's also interactions with the drugs you're giving and the the therapy for their heart failure. I mean, their transplant, because a lot of the drugs metabolize in the same way and will change the levels.
Okay.
So it's Joe. I have a totally countercurrent argument here to what I would usually think about. The first is that I don't think that this heart is any more susceptible to anthracycline damage than any other heart. However, in somebody with a transplant, if the oncologists were happy with TCH, I would stay away from anthracyclines only because of the emotional and potential of somebody who already had a heart transplant to screw up their heart transplant.
Do you have data that shows that anthracycline?
Yeah, I mean, I think if there's equipoise for breast cancer with avoiding an anthracycline here, this is one time I would probably like to do it because, again, if somebody's already had a heart transplant, if she develops cardiomyopathy and is jeopardized, I think that we're not doing her. It's it's more of a disservice than the regular person.
Have you seen any research to support any of that?
No, I mean, it's just based on the fact that, that this heart has the same likelihood of developing a cardiomyopathy as my heart or your heart. And because there is that risk, I would probably stay away from anthracyclines.
So I think over time we'll certainly have to try to come up with some type of registry so that we can follow patients such as this patient throughout their treatment of their cancers, to be able to have more data to know what to do with evidence-based research. Other considerations for this patient would be, should any of these different chemotherapies be utilized, anthracyclines, trastuzumabs, would your screenings to monitor allograft function change in comparison to the general population? We really felt that we would, should this patient utilize any of those chemotherapies, that we would screen allograft function more frequently than someone else who did not have a heart transplant.
Yeah, I mean, if I were seeing that patient as Crohn again, I would be following, there aren't many biomarkers to follow. I mean, BNP and troponin, but I would definitely follow them closely before and after treatment for sure, and then maybe even additional times, because you really need to get on top of this. And you might even consider at some point MRI to look for inflammation or something in the transplant. I mean, I don't know. This would be, it's all N of one. You're sort of flying by the seat of your pants.
Well, I mean, I think those are great, because I think we struggle with a signal that truly indicates or that truly predicts allograft dysfunction, or rather cardiac dysfunction, and then you take it one level higher, which is allograft dysfunction. We know that oftentimes BNPs are elevated in these allografts and maybe even have some low troponin leak that has no consequence to allograft function at that period of time, but we also know that those same individuals over time probably have a smoldering rejection of some sort or another that predisposes to allograft dysfunction. And then you compound that with potentially agents that would have, effects on the myocardium.
And I think you bring up a good point of cardiac MRI. That was something that we had discussed for this patient. Should she utilize any of these chemotherapies, would that have an indication to be able to find changes earlier than an echocardiogram would show, or biomarkers?
Yeah, I haven't used it very often, but when I have, it's been very, very instructive. Like a person with unexplained cardiomyopathy with troponin elevation, and then the MRI shows inflammation. And I think in this kind of patient, you can't assume that the ejection fraction drops, it's going to bounce back like it so often does in these other patients.
We use the MRI all the time, and you can do an MRI strain. There's something called sync where you do MRI strain on one heartbeat. Pretty convenient, and so you don't have to be in the scanner long to get a strain as another indices and compare with the strain that you already have on the echo.
So that's one of the challenges that I think is that we have all of these kind of different imaging modalities to assess cardiac function, and one of the downsides is that they're not exactly superimposable. So an MRI strain is different than an echo strain that may be different than others. So I think choosing the imaging modality and then following the patient with the same imaging modality maybe of some benefit as we think about the frequency with which things are done. I think certainly if there's a change in the pattern or something else occurs, a higher level of imaging may be worthwhile under those circumstances.
Oh, it's definitely.
All right. And then other thoughts that we had, would we change our immunosuppression regimen based on cancer treatment, platelet counts, whatnot, or just due to the cancer itself? Would we decrease our immunosuppression? Typically, we do at our center. If someone is diagnosed with cancer, we decrease their immunosuppression, monitor their allograft function, as well as their levels.
Does anybody have experience with that? I mean, I'm a transplant cardiologist. That's what I've been doing for 15 years. And anytime that I have had a patient who has the bad combination of solid organ transplantation and a cancer, the cancer is often in the later phases of illness. It is often metastatic, and if not, the disease progression is often more aggressive, at least based on what I've seen anecdotally and of just me. So what I have done is consistently reduce immunosuppression in these folks with an emphasis on trying monotherapy. And monotherapy for heart transplantation is a calcineurin inhibitor. And there is safety data for monotherapy in selected groups of patients. So that's what we've strived to do in our program.
If I could just interject and another thought, this conference is spectacular in a sense. It's getting together a lot of people with a lot of different experience. Although some of the places, the best people aren't on the phone. And I would just put in a plea now while I'm thinking about it that perhaps we ought to just send out a email to everybody and get the people that are interested in cardio-oncology and doing transplant to put their names together and perhaps carry on this conversation perhaps and put it in print someplace. Because I think that this is really unique and there is nothing in the literature. I don't know if anybody wants to do that.
I would second that, and
right.
We would welcome the use of this forum in that regard, but we certainly don't want to impose the world of heart transplantation within the field of cardio-oncology, although it seems to be a reasonable fit.
Sebastian, go ahead.
Sorry. No, go ahead. I was just going to say that, starting with the cardio-oncologist, I think that's the place to reach out to the transplant people. Because, I mean, most transplant people are not really that, I don't think they're that interested in it specifically. But the cardio-oncologists see this as a real opportunity to make a contribution, I would think.
Sebastian would be interested in publishing this dialogue in their journal, which is geared towards cardio-oncology. And we actually submitted a case of someone that had cardiac toxicity from having had bone cancer and received daunorubramycin and basically his transplant and then 33-year follow-up, and we published that in his journal as an anecdotal case.
Can you hear me? Hi everybody, can you hear me?
Yeah, Sebastian, yeah. How are you?
Best greeting from Europe. Congratulations for the presentation. I'm impressed hearing you. I haven't such patients, but I know that my colleagues from Germany, from UK have such patients, and they will try to treat them. But I haven't own experience in such patients, so I don't know which type of chemotherapy can be used in this population. But I think that we can think about optimal treatment, because patients after heart transplantation may be understood as patients with heavy heart muscle. So I prefer optimal chemotherapy. What do you think about this option? I think that we can use chemotherapy with anthracycline and of course with trastuzumab, and we should look at early sign of cardiotoxicity, but we should use the optimal treatment for cancer. What do you think?
So I tend to, Sebastian, this is Vinay Tohan. I tend to be, I completely agree with you for the comments, for the sentiment that I have in reference to cancer and solid organ transplant is that it tends to be a more aggressive illness, tends to be metastatic at the time of diagnosis, and it tends to be more difficult to treat. So I am always of the opinion to be the most aggressive with the cancer therapy. We can deal with what happens with the heart down the road, but to be very aggressive with the cancer therapy, I mean, obviously safeguards in place. You know, we would obviously screen for early toxicities and other things, but I would be the most aggressive, including surgical resection. If there's a decision between surgical resection and local treatment in a solid organ transplant patient, I'm almost always pushing for surgical resection, even if the data is of equipoise in the routine non-immunocompromised patient.
Yes, I agree.
Dr. Ping also agrees with the idea of wanting to get everybody together and publish this as dialogue and get some transplant cardiologists involved so we could actually have another presentation and invite our transplant colleagues.
I think other things we looked at were, does the immunosuppression affect the efficacy of cancer treatment? Someone had been speaking regarding the interactions between the drugs, and how does that affect the actual cancer treatment? We also need to adjust immunosuppression, at least in our program we typically do, and does this affect the allograft function? And we do routine and more frequent echocardiogram and allograft function evaluation. And given what Dr. Tohan had been speaking about earlier, how our solid organ transplant patients, when cancers do present themselves, they tend to be more advanced stages, more metastatic, and just a higher level of cancer, more difficult to treat, more aggressive. Would you consider increasing the frequency of preventative cancer screenings post-transplant patients? The literature really discusses using the same cancer preventative screenings as we do for the general population. Would we increase that?
So maybe I'll make a comment here. I'll give you an example of a patient, not uncommon, that we see in the transplant arena is an individual who has Barrett's esophagus, for instance. And we know that the chances of progression of Barrett's esophagus to esophageal cancer is less than 1%. But what happens to Barrett's esophagus in a solid organ transplant patient? What is the progression of Barrett's to esophageal cancer in that population of patients? You know, those are kinds of questions we struggle with because you have to balance, you know, immunosuppression with cancer risk and cancer progression. That's a natural. But then when you have a pre-malignant state like Barrett's, you know, how do you then balance that, and what is the true risk when you fully immunosuppress somebody? Silence means the paucity of data.
Correct.
Paucity of data, and no opinion. That's kind of a very difficult place for physicians to be in.
Well, I think you have to screen more carefully, because if it does crop up, you're in a bad position, as Joe was saying earlier. That you have to be on top of these things. So it may not be cost effective necessarily, but I think you have to demonstrate to your patients that you're really on the ball, at the very least, whether it has any real meaning or not. That's not the answer.
That's our thought as well. I think sometimes insurance can get in the way of some of that.
Yeah.
So looking at the ISHLT data and their recommendations for immunosuppression therapy, at this point, the guidelines from 2010, which are the most current, do not suggest changing immunosuppression unless it affects the lymphoid system. But if you look, there's really no data to support that. It's just kind of general consensus. And then immunosuppression adjustment just based on labs and other indications that might arise, like infections, whatnot. So going back to our patient, she did have surgery, and she was found to have no metastasis to lymph nodes. Met with the medical oncologist, radiation oncologist, and our medical oncologist recommended the surgery plus radiation, and 5 years of tamoxifen, or surgery, radiation, and 5 years of aromatase inhibitors.
So I don't know enough about breast cancer, but she certainly has receptor positive. I don't know if they screened her for HER2 positive or not, and whether that's even done in patients that are non-advanced.
Risk the heart or treat the cancer properly. Consensus seems to be treat the cancer.
So you have to work.
Any comments about that then?
I think that is a good option. I agree. I think that the risk of thromboembolic complications may be very low, and aromatase inhibitor together with immunotherapy, immunosuppressor, may have very good beneficial prognosis, I think.
I feel like if they offer the ERB2 and the ERB2 expression level, then it's better for us to choose the chemotherapy drugs. Do they have the ERB2 expression level for this patient?
We didn't see it in the biopsy, but I suspect that I suspect that the oncologist would want that information as they're designing their treatment options.
Yeah.
I don't know enough about breast cancer to know that for local disease, sentinel lymph node negative, whether the ERB2 receptor is relevant to the discussion for therapy. It looks like radiation is the option.
Mm-hmm.
So it's Joe again. I would just add that hopefully that radiation is going to be done in a place where they do major cardiac sparing techniques with organized breath holding and possibly upright position rather than supine, and at Penn at least we've been studying low dose radiation fewer treatments with the same efficacy. So it's important to make sure that the rad-onc guys are in tune with the program.
Thank you for bringing that up. That was one of my other points with this patient, with any patient, but with this specifically being on immunosuppression, which can cause coronary artery vasculopathy, then radiation can enhance that or cause coronary artery disease as well. So I think utilizing that cardiac sparing radiation therapy is very important in any patient, but especially in this patient.
Yeah, and this actually might be a place where if you have access to protons, it may be better than traditional photon therapy.
I think that radiation should be safe in this patient.
Say that again. I'm sorry, Sebastian.
I would prefer radiation with aromatase inhibitor because I think that modern radiation should be safe, and 5 years of aromatase inhibitor together with immunosuppression should have the optimal outcome in this patient. This is my opinion. The last option.
Mm-hmm. Again, aggressive options for these patients. We actually, the radiation oncologist actually was comfortable with monitoring, just watching the patient over time, not giving any radiation. And I'm not sure that we're going to settle on that. This is still a sort of fresh case evolving, but I'm not sure we're going to settle on that.
When we can use the modern radiation with low doses of radiotherapy, I think that this option is quite safe.
Well, we will definitely utilize your expertise when we discuss this with our oncology colleagues and our radiation onc colleagues, and we really appreciate that input.
So do you have proton beam therapy?
I don't know the sorry, I mean, I don't know the data there about the radiation effect on the vascular in the heart. So it really depends on that, how it affects for the DNA damage, I know. So.
Well, if you look at radiation in general, and this is old data, but it's dose-dependent, site-dependent, and associated chemo-dependent as far as the cardiac toxicities are concerned. And the dose does make a difference, and the field does make a difference in reference to things like valvular heart disease and ischemic heart disease. Now you compound that with chronic immune injury, which occurs in the transplanted state, we won't know the natural history of radiation to a heart who is predisposed to developing premature atherosclerosis anyway.
Yeah. So it seems like everything is new. So it's trying a dose that connect the data to see if it will be helpful for the next case or for future case. Because probably there's no data there for the patients who had a transplantation and also had a heart and needs to do this radiation therapy and with the chemotherapy.
Agree. I think in preparing this case presentation, really looking for data, I do agree that we really need to get a group together to go through these patients and put all the data together so that we can treat these patients with the best evidence-based treatment for treatment of their cancer as well as preserved allograft function. Any other questions, thoughts, comments?
Let's see, I guess you don't have proton beam in Wisconsin, but I know they have the pencil beam therapy proton in Mayo, and so that would be an option if it's close enough and you have a working relationship. The patient would have to go there to live for a while, though.
I would say this lady has, from a heart transplant side of things, she's done exceptionally well, and this diagnosis, I don't know, would be the most proximal mechanism. If you just look at outcomes for heart transplantation in general, the conditional survival now is 14.5 years, and I would suggest that and cancer really is sort of the second or third most common cause of mortality in the post-transplant period, depending on the time frame that you look at. So, you have competing risks in these two conditions. And I think that's, again, how do we balance this in the context of competing risks?
All right. So I think from this, with this particular case, we'll meet with the medical oncologist and the radiation oncologist and recommend treatment versus observation. I do think that getting the transplant team and who have an interest in cardio-oncology so that we can further put together this data and publish some of it would be ideal. And that's all I have.
That's all we got.
Okay, very good. Well, that was certainly an interesting case. We really appreciated that. Keep in mind that Sebastian is looking for case reports, and this would be a good one, especially with our discussion, which we have recorded. And so, Sebastian, and with the permission of the group there, if you could send your case report to Sebastian from Aurora, he would appreciate that, and I can send him a copy of this recording.
I can do that. I just would need his contact information.
Sebastian,
yes.
Can you help us?
Yes, of course. Yes, of course. I would like to publish this case in our journal on co-review, and we will invite other experts to comment this case.
Okay. Sounds great.
I know that we are a little bit early, but if there's no other discussion, Eric, thoughts?
No, thank you, Calvert. We appreciate your coming. Joe, your comments were appreciated. Lauren, Maria Santos, Mark Westwood, Nelson Murillo, Sebastian, of course, Serena Messar, and our colleague, Dr. Ping from China. We appreciate our staff. And Jodi, thank you very much for your presentation. It was very good. And please, you can get in touch with Nadine, and she will get you the email address for Sebastian so you can get in touch to publish this as an article with our dialogue as well. Thank you so much.
Thank you. Congratulations.
We'll see you next month.
All right, sounds good. Thanks.